science leads us to new knowledge, and new knowledge leads us to understand the world in a better way.
I like to say that the biosphere was the original World Wide Web.
There's nothing right about giving a machine the right to kill people.
To understand the world, the extremes will not do it. We need to look at the majority to understand what's going on.
Hello and welcome to the inaugural David Cooper Lecture. I'd like to begin by acknowledging the traditional owners of the land from which I'm joining you today, the Bidjigal people of the Eora Nation, and pay my respects to elders past, present and emerging. My name is Anthony Kelleher. I am the Director of the Kirby Institute, and it's my pleasure to welcome you to this very special virtual event. This annual lecture pays tribute to the Kirby Institute's inaugural director, Professor David Cooper AC. David was a physician trained as an immunologist and a researcher, an exemplar clinician scientist. In 1986, he was appointed by the Australian federal government to lead its newly established HIV Research Centre in Epidemiology and Clinical Research, which was set up in response to the HIV epidemic that was then taking hold of Australia and around the globe. David led that centre, now known as the Kirby Institute, with intellectual rigour, drive, determination and insight for 32 years, right up until his untimely passing in 2018. David was involved in the development of every HIV drug approved in Australia, making important discoveries and providing the evidence base that informed and drove not only the Australian response, but also the international response to HIV. David was a mentor and friend to many of us at the Kirby Institute, myself included, and it is an honour to commemorate and continue his legacy in this way. The path he set us on as a bench-to-bedside infectious diseases research centre has enabled the Kirby Institute to quickly respond to COVID-19 across the breadth of our research disciplines. We are extremely privileged that Dr. Anthony S. Fauci has taken this time out of his incredibly busy schedule to give the inaugural David Cooper Lecture. As two leaders in HIV research in their respective countries, both trained in clinical immunology, Dr. Fauci and David Cooper would cross paths through their work, especially in the early years of the HIV epidemic. Driven by scientific evidence, they pushed forward the global response, made important discoveries about HIV and strove for a common cause: to prevent, treat and improve the lives of those living with HIV, and in doing so, ensure the dignity and human rights of all who were affected by the virus, regardless of their circumstances. This work continues to this day across a range of infectious diseases. We are very fortunate that Tegan Taylor is with us to lead this special In Conversation with Dr. Fauci. Tegan is co-host of the ABC's Coronacast, a multi-award-winning daily podcast about the coronavirus, which last year won a prestigious Walkley Award, as well as the prestigious Eureka Prize for Science Journalism. Tegan has had an extensive journalistic career, including as a lecturer in journalism at the University of Queensland, and today is a health reporter in the ABC's Science Unit, where she reports on topics from stem cells to fad diets and, of course, COVID-19. You are now about to hear from a number of David's former colleagues who will share their reflections on the incredible impact he made, followed by the inaugural David Cooper Lecture, where we will hear from Dr. Anthony Fauci in conversation with Tegan Taylor.
I wanted to be involved in this video to recognize somebody I regarded as a great man.
I think one of David's great strengths was that he had the ability to see the big picture but also he was very good at looking after the individual. Many of us are very good at one or the other, but not both. But David encompassed the lot.
He cared deeply about us. And it showed every time we went to see him.
Well, I think that the challenge for a young doctor, or relatively young doctor like that, was that he was hands-on in a way that we who were making policy or even the senior medical men were not. And I think that gave him a humanity and an understanding and a recognition of the social and personal, not just the medical problems. And that's the importance about treating this disease, was to recognise the social and individual problems as distinct from the particular disease problem.
But you can add to that, he was the first one in the world to describe the seroconversion illness, and he was so modest about it. He would never tell you what he'd done, and yet he'd done so much.
Oh, I first met David in 1983 when I was a GP in Darlinghurst. Yeah, I remember we had to do a bit of a re-education job on David. He wasn't all that aware of the sexual mores or the cultural mores of downtown Darlinghurst.
He's also an inspirational person, so that the people around him were inspired to do things, and they will continue to be inspired, and it's thanks to him.
This man contributed immensely, and absolutely his work should continue, and all of us should be committed to it.
So David helped us make clear what the real problems were and what the questions were that we had to answer, and he showed us the way we had to go.
He and others, of course, did a lot to persuade us that we had to have a bipartisan approach to this disease. We couldn't allow it to wreck policy as it had done in the United States.
And we got a bipartisan approach.
David Cooper always talked about, sisters, I'm a good Jewish man, and you and I, the Sisters of Charity and this good Jewish man, we need to get together and we need to support each other. He was such an advocate.
He was such an important part of our lives. He saved mine, he saved so many people's lives. I'd say right man, right place, right time. You know, we're lucky we had him. I can't imagine the AIDS epidemic without David Cooper.
Hello and welcome to the inaugural David Cooper Lecture with Dr. Anthony S. Fauci. My name is Tegan Taylor and I'm a health and science journalist at the ABC. Firstly, I would like to acknowledge the Bidjigal people that are the traditional custodians of this land. I'd also like to pay my respects to elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are joining us today. To join the digital conversation during tonight's event, please feel free to comment on Facebook, use the live chat function on YouTube, or send us a tweet, and don't forget to hashtag UNSW Ideas. This event is co-presented by the UNSW Centre for Ideas, the Kirby Institute, and UNSW Medicine and Health, and we're thrilled to be joined by Dr. Anthony Fauci. Dr. Fauci, thank you for joining us.
Good to be with you. Thank you for having me.
Dr. Anthony Fauci, for those of you who don't know, is the director of the National Institute of Allergy and Infectious Diseases at the US National Institutes of Health, where he oversees research on infectious and immune-mediated diseases. Dr. Fauci's contributions to research are too many to mention here. In fact, he's one of the world's most cited biomedical scientists. He was one of the principal architects of the President's Emergency Plan for AIDS Relief, a program that has saved millions of lives throughout the developing world. So Dr. Fauci, let's jump right in. Australia often likes to compare itself with America, but our COVID experience has been very different. Why do you think that is?
Well, you know, I think it's important that what the Australians did is that they had, I believe, at least looking at it from a distance and in discussing with my Australian friends and colleagues, that you had the capability and the uniformity of your citizens, that when you shut down, you really shut down very effectively. You got a level down to essentially as low as you possibly could get. And then when you had a situation where you opened up again, you responded quickly and efficiently. And I'm sure not everybody in Australia was excited about having to shut things down, but you did it in a way which was really quite uniform, but importantly effective. If you look at the United States, you know, we have 50 separate states and territories in addition to the 50 states. And part of our government structure is that the states have a degree of independence to do what it is that they want to do. They have interactions with the central government, but they have a great deal of leeway. And we had an inconsistent response, which allowed us, unfortunately for us, to really do worse than essentially any other country, which is really extremely unfortunate. We now have over 555,000 deaths. And as of this past weekend, we had up to 80,000 new infections in this country. So it's a complicated situation. Australia, I believe, was one of the better countries in the entire world in how you responded. And unfortunately, we have not done nearly as well as we should have done.
It's sort of a cultural thing, though, isn't it? Like, Australia has a quarantine culture with the biosecurity, and America is a very, very proud of its independence and the independence of its citizens. How do you change something like that at a country level?
It was very difficult to do. You know, what we had, again, I'm a very loyal American, but I'm a realist too. And I see what is going on, you know, in our country. It is unfortunate that we are living right now in our country in a time of profound divisiveness. I think anyone who pays any attention to what's going on in the United States sees that. Now, in some respects, that happens in different countries. But when it spills over in the middle of the worst, most historic pandemic of a respiratory disease that we've had in over 100 years, if there's anything you want, is you want people to be pulling together in uniform. It's sort of like being at a war. The common enemy is the virus, and we should all be fighting the virus and not fighting with each other. So that has really been one of the real difficulties that we've had to face during this now 14 months and still counting with this epidemic.
And that needs to be led from the top, and it's no secret that you and President Trump there were difficulties in having a consistent, cohesive approach there. Has that shifted now that Biden's taken office?
You know, it certainly has from the top. There's no doubt about it that President Biden wants science to rule. He said that behind the scenes to us on his medical team, and he has said it publicly, that we're going to be driven and ruled by science and facts. And when something goes wrong, we'll try and fix it, and we won't blame anyone. That has worked extremely well. However, we still have a degree of divisiveness in the country, and we still have situations where governors, because of their independence, are essentially defying some of the recommendations and the guidelines of public health, which is one of the reasons, together with the variants, why I believe, despite our great success with vaccines, we're sort of in a race between the potential for a real surging of cases and the fact that we're putting vaccines into people's arms extremely efficiently.
That's been a constant challenge for you throughout your career, though. You've advised 7 presidents over decades, and there's sort of 2 jobs that you're doing, isn't there? You're sort of managing up to the president, but you're also the head of, you're managing communication to an entire nation. How do you balance that managing up and also that public health messaging?
Well, most of the time, it is, I wouldn't say easy, it's never easy, but with some challenges, it works well. One of the difficulties that we had over the previous months, not recently, but last year, in the middle of the height of what was going on, is that I had to, and it was very painful to do, but I had to do it, come out and essentially contradict what the president was saying, which is a very difficult thing to do. And it led to some obviously strain and stress between us, which even now, after the former president is no longer in office, he still talks about that, which is unfortunate.
Well, so we put out the call to our audience for questions, and we got hundreds of questions, and I'm not going to pepper you with all of them. But you mentioned before the vaccine rollout, and UNSW alumnus Carla Burnett said the US struggled at the start of its vaccine rollout, but has seemed to have picked up the slack, and Australia is also struggling with its vaccine rollout at the moment, and wondering what advice the US can give to Australia in this regard.
Yes, to the extent that it's possible, what President Biden did is that he made it the very, very top priority. He put in a substantial amount of resources. He made equity a very important part of this. And what he's done, for example, is open up community vaccine centers, get vaccines to the pharmacies, develop mobile units to go out to get to people who are in poorly accessible areas, and got vaccinators, namely people who would be administering the vaccine. He got as many of them out into the field as he possibly could. Those are retired physicians, military personnel, nurses, medical students, as many people as you possibly can to get out there and administer it. So it was really making it the highest priority to get vaccine into people's arms, and it works. I mean, we had just the day before yesterday, I believe it was, we had 4.6 million vaccinations performed in a single day. That was a record that was really quite impressive. If we keep doing that over the next few months, I believe we will finally get the overwhelming majority of the people vaccinated in the next several months, which I hope will then turn things around and get that level of daily infections down to a manageable level.
How worried are you about variants?
I mean, I'm always concerned about variants in general. There are some variants that are handled extremely well by the vaccine. Fortunately for us, the B117, which is sometimes referred to as the UK variant, we don't like to say that because that makes it seem like the UK's at fault, which they're not. It just happened, we believe, to take hold there, and now it is becoming the dominant variant in the United States. The vaccine works well against it. The trouble is that variant has the capability of spreading much more efficiently than the original virus that seeded this country. So we're going to have an issue of what I would call a race between getting people vaccinated and not getting another surge. There are other variants that are of greater concern. Fortunately, they are not dominant in this country, and I refer specifically to the South African variant, the 351, which actually diminishes by several-fold the capability of a vaccine to protect someone against infection. You do still pretty well against severe disease and death, but against infection, it diminishes it below what the standard degree of efficacy is against most other strains.
So you mentioned before about vaccination being something that everyone's to do, that idea of health equity. And Sophia Henning, who's a UNSW student, was asking about whether you think that the COVID-19 health crisis in the USA has increased American public support for universal health care, or if it's further entrenched the current model.
Well, as you know, the Affordable Care Act was one that attempted to get to that point that you're referring. It needs to be improved and will be improved. as you know, there was attempts to essentially destroy that, and that has been unsuccessful because there's been no alternative for it. But we really feel strongly that if we get the Affordable Care Act with some improvements in it, that we would have what would be the equivalent to universal health coverage.
So everyone has been well, not everyone, epidemiologists and virologists and infectious disease experts have been predicting a global pandemic for years. And it was called Disease X and it was inevitable, but it happened. When was the moment that you realised that COVID-19 was going to be a big deal?
Well, it was a gradual issue. And one of the things that prevented us from knowing right off that it was going to be a big deal was the early lack of transparency on the part of China, which is really unfortunate. Not all Chinese, but the Chinese officials, because the scientists that have been our colleagues for years, in some respects, some of them were not allowed to really openly talk about it, because you might recall that the first inkling of something going wrong was a new type of pneumonia was coming out of Wuhan. And it was felt that, well, it was similar to SARS, the original SARS, where it jumped species from an animal somewhere in the environment of the wet market in Wuhan. So the standard line then was, well, it doesn't really spread very efficiently from human to human. It's merely just jumping from an animal to a human. And then after a little bit, it was, well, it goes from human to human. And then after another little bit, well, it goes really efficiently from human to human. And then finally, and by the way, it's a very unusual virus because it spreads from people who aren't even symptomatic. So we knew there was a problem when China was doing all the things they were doing, building like field hospitals, practically overnight, that they wouldn't be doing that unless there was a situation that they felt was really dire. When we got hit in New York City, and it was very clear that we were having rapid spread of this virus with a very dire consequence among certain subgroups, such as the elderly and those with underlying conditions, it became very clear after that second month or so that this was not going to go away. This was really a serious historic problem.
Yeah, I suppose China perhaps wasn't transparent at the beginning, but they did mobilise really quickly, which the rest of the world has also had to learn to do. And despite that early hesitancy to be transparent, the pandemic has really been characterised by international collaboration.
Well, there's no doubt. I mean, a global pandemic requires a global response. And a global response includes transparency, and includes sharing of information, includes international clinical trials, which is, the reason why I was so pleased when on the first day of President Biden's presidency, he asked me to represent him at the executive board of the WHO and to announce to the world that we were re-entering the World Health Organization and we were going to become an active part of COVAX. So that, I think, is something that took a while, but finally we're back where we should be, the United States as an important part of a global effort.
So obviously the United States has a lot of work to do to protect its own citizens, but what responsibility do you think that wealthy nations like the US and Australia have to the developing world?
I think we do. I mean, it was my strong feeling of that responsibility which prompted me to play a major role in developing the PEPFAR program, the President's Emergency Plans for AIDS Relief, which, as you probably know, has saved now up to 14 million lives. I believe that the developed world has a responsibility to assist the developing world in things that are not readily available to them. And that's the reason why we started COVAX. We didn't start COVAX, we joined COVAX. Namely, we have a situation where we've pledged or given $4 billion. We will clearly, when we get our people vaccinated, be very seriously consider it. And I'm saying not only consider, but we will share some of the excess vaccines that we have. And I think we also would like to perhaps be part of a movement to allow some of the developing countries to produce vaccine on their own, to give them the capability of being able to produce it rather than relying on outsiders to give it to them.
Because it's not just about, it is philanthropical to go and help developing nations, but it also helps all of us. We're all humans with the same biology, and variants that emerge in other nations still threaten the developed world as well.
Yeah. No, you're absolutely right. And I think that's the critical issue that I have, personally as a public health person, have felt so strongly about, that particularly when you have a disease, an infection that spreads so easily and so efficiently as this virus does, that even if you control it well in your own country, the way Australia's done, the way we hope to do, the way many of the European countries, even though they're going through a terrible time with surges now in several of the countries of the European Union, when you ultimately get it controlled, if you want to maintain the control, you want to have control throughout the entire world. Because as long as there's the dynamic of virus replication somewhere, there will always be the threat of the emergence of variants, which could then come back. And even though most of the rest of the world is vaccinated, it can threaten the world that has felt that they've controlled the virus when they're still quite vulnerable.
What is our way out globally then? Because last year it was all like, we've just got to get through 2020, and now we're in 2021 and it still hasn't quit. Where to from here?
Yeah, I believe vaccination is the answer. I mean, variants are a problem, no doubt, but we are fortunate, given the investments that were made in biomedical research over so many years, due to the extraordinary advances in vaccine platform technology and structure-based design of immunogens that are optimal immunogens, that we now have several vaccines that are highly efficacious. And when put into the field, that efficacious becomes quite effective. And we're seeing that in my country, in which when we vaccinate people, we see that it really does work out there in the field. The issue is we've got to get the overwhelming majority of the population vaccinated, which brings us, to another one of the potential stumbling blocks that we have in the United States, is what we call vaccine hesitancy, where people don't want to get vaccinated for reasons that don't seem to have anything to do with public health. It's unjustified skepticism. It's a political ideology where you look, how could it be that a certain proportion of people of a particular persuasion don't want to get vaccinated? That just doesn't make any sense. What does vaccine, which is directly related to public health, and over decades, if not centuries, has proven to be the most extraordinary preventive modality that you have for infectious diseases, how does the acceptance of that or not become a political issue? But unfortunately, in many respects, it has.
Vaccine hesitancy is nothing new. People have been hesitant about vaccines since they were invented, but it does seem to be a real issue at the moment. And like you say, political. How do you think that's evolved to be the case?
I think it's first of all, it's complicated. So I think I'm not going to give you a 5-word, quick answer to it. It really is a complication of an anti-science atmosphere that has evolved, again, with a certain type of political persuasion that scientists don't know what they're talking about. A lot of this is fake news. A lot of it doesn't really exist. I mean, to say things like that when you have a terrible pandemic looking you straight in the eye, in some respects is almost inexplicable. But unfortunately, it's happening. And that's one of the real issues that I said right from the get-go. One of the more difficult aspects of this entire endeavor here is that it has occurred in a situation of very intense divisiveness in our country. And also, not just the United States, we're seeing some of that in the European Union also.
So this is the David Cooper Memorial Lecture. David Cooper pioneered AIDS research in Australia, and one of the things that really worked for his work here in Australia was partnering with the LGBTQ community, and I know that that's something that you came around to as well in your work. Does a similar approach need to be taken for COVID-19, where there's some more kind of community level public health messaging happening for these people who are really resistant?
I wish that were the case. I really do. When I dealt, and that has been a very important part, I believe, of what I did and what David did in Australia. And David and I were very good friends for many, many years, way before HIV and AIDS came along, actually, when he was a fellow with Ron Penny. So we had the same attitude that you needed to reach out, because the community, when they were essentially pushing back against the scientific establishment and against the regulatory establishment, because they felt justifiably and correctly that we were not giving them a voice in what was directly affecting them, in the design of clinical trials, in the loosening of the regulatory issues that we were taking years and years to make decisions about drugs when they, at that time, had a lifespan measured in a year or less. So although they were being iconoclastic, they were being disruptive, it wasn't a political difference. It was a difference in saying, listen to us because we feel we should have a voice in what gets done. And they were absolutely correct. So when I extended myself to them and said, let me listen to what you have to say, what they had to say made absolute sense. And I said to myself, if I were in their shoes, I would be doing exactly what they're doing. That is an entirely different situation from someone that tells you that this is all a hoax and it's fake news and it doesn't exist. There's a big difference there. So although I would love and do extend myself with a substantial investment of time to get people to get vaccinated, the hardcore ones that don't want to for political reasons, I don't think I could change their mind. If someone has a hesitancy because they have a doubt about was it done too quickly, or we have a very important situation in our country with our minorities, our African Americans and Hispanics, our brown and black people, because they justifiably are somewhat skeptical about anything the government does because of the way they have been treated. So the way we get to them is we totally respect their skepticism and say, let's together try to work our way through this. Because the reason for your skepticism, even though we have many, many guardrails in place now to prevent those injustices from coming now, the fact is the history of the injustices to you are real. So we respect it. Once you get past that, then you could say, "Lo, it wasn't done too quickly. It was only a reflection of spectacular advances in science. It wasn't done carelessly. There's a good reason to do it. Here are what the data look like. Look at the data." When they see the data, they say, "I'm convinced. I think I'll do it." But the hardcore people who do it, who are resistant for other reasons, it's going to be very tough to turn them around.
So when you're coming alongside people and earning their trust first and then kind of blasting them with facts later. What do you do about the hopefully minority who just got their fingers in their ears?
Well, what we hope happens is that when they see more and more people get vaccinated and they see the actual protection among those people who are getting vaccinated, that they will ultimately have common sense take over and say, this is good for me, and quite frankly, is also good for the country. Because there are a couple of reasons to get vaccinated. One is for your own personal health, and the other is for what you consider your societal responsibility to have your society protected by this overwhelming veil of immunity that comes over the country when you get so many people vaccinated.
So we mentioned before that early in your career was the AIDS epidemic. What did you learn during that time that has sort of informed the rest of your career up until now?
Well, there are several things about it. I mean, scientifically, what I learned, and I've been dealing with this now, HIV/AIDS is still very much on the radar screen. I've been doing it for 40 years now. But it is, impressed upon me that new infections have always emerged. They are emerging now, and they will continue to emerge. So the lesson learned is that to the extent possible, prepare yourself as best as you possibly can. And there are a couple of ways to prepare. You can prepare by building a good public health global infrastructure, the Global Health Security Network, for example, by having the kind of transparencies that we mentioned a little bit ago when we were talking about China. The idea that we make investments in public health infrastructure, which interestingly, in the United States, we've let be a victim of attrition, the local public health. The other thing that I feel as a scientist is as important of all of that is the investment in fundamental, basic, and applied science, which will allow you to respond quickly when you do get an emerging infection. And by quickly, I mean doing things like building on prototype pathogen experience. What we mean by that is, for example, we developed, I'll give you a very brief story about the immunogen that is so successful right now, the spike protein in the right conformation to induce the best immune response. That was an interdisciplinary effort of structural biologists, X-ray crystallographers, cryo-EM experts that were able to study the conformation of molecules that you can then, by mutating them, keep them in a stable form to be used as an immunogen. It was years of work developing new platform technologies like the mRNA. It's that kind of investment in research that generically forwards and advances all of the things that you can do, so that when you get confronted with an outbreak, that outbreak doesn't turn into a global pandemic. And that's the thing that I've learned over the years.
Yeah, I think the public and politicians as well often want scientists to just be able to pull a rabbit out of a hat, but you need to be laying that groundwork in the good times so that when these pathogens emerge, you're ready, like you say. So the Kirby Institute's involved in some major NIH-sponsored COVID and HIV trials, and there's been a lot of talk about the current global research effort as being unprecedented, but actually a lot of the foundations for this were laid in the AIDS epidemic. What sort of international collaborations that began with HIV have helped the COVID research effort?
Well, there's one that is really important, and that is back in the mid to late 1980s, mostly the mid 80s, I began in my institute to build a clinical trials network that was global. And what we did is that we made major investments into clinical trial sites to train and fund investigators throughout the world, including people like my good friend David Cooper and others, including many of the very talented Australian investigators. We did it in Africa, we did it in Asia, we did it in South America, we did it in the Caribbean, and we did it in Europe. So now, when you have the need to do international clinical trials, you can actually call upon the experienced investigators who for decades, both they and their trainees and their mentors had successfully done clinical trials with HIV, be they prevention trials, be they vaccine trials, be they drug therapy trials. They had a lot of experience. So it was that investment and that experience that was gained very successfully with HIV/AIDS that allowed us to spring out of the box quickly and very effectively in clinical trials with COVID-19.
What is the benefit practically of having the ability to do those sorts of trials in different parts of the world?
Well, because sometimes disease is not uniform in different countries. And when you have a network that expands throughout the world, there may be a hot spot in one area and you do the trials there that would benefit the rest of the world. Or there may be different conditions in different parts of the world that you want to learn about what the best ways to prevent under various conditions. I mean, what goes on, for example, in KwaZulu-Natal in South Africa, in many respects is different from the profile that you see in Sydney or Melbourne. It's very different than what you might see in Italy or in Canada. And the same thing holds true for Thailand versus Haiti. So you really got to have a broad umbrella of clinical trial sites and capabilities of studying very different aspects of the outbreak under different conditions.
And sort of on that theme of really equity, global equity, Jane Costello, who's partner of the University of New South Wales, she's the CEO of Positive Life New South Wales, which represents people who are HIV positive. She was asking about your reflections on the role that stigma has played in both the AIDS epidemic and the COVID epidemic.
Yeah, well, stigma has clearly played almost an acute negative impact on HIV. The stigma associated with a disenfranchised group, namely gay men back then, who were not too long before 1981, finally were able to express their own sexual identity freedom with the famous Stonewall riot in the bar in Greenwich Village, which allowed them to finally be out there with their own identity, but the stigma against gay men then, and against commercial sex workers, and against injection drug users in a disease that was mysterious was really, it's much more improved now, much better, but it was really a problem back then. And in some respects still lingers. Stigma in some other countries still to this day, 40 years later, is a problem. In certain regions and sections of Southern Africa, the stigma associated with HIV is still there. And again, that has, in some respects, attenuated a bit, but it still lingers. Less than stigma with regard to COVID-19, I have found that at least in my own country, it has shed a very bright light, the disease has, on the health disparities in my country. Because we know that African Americans and Hispanics have a higher incidence of infection because of the nature of the jobs they have. They're essential workers in society more often than not. But also, importantly, due to the conditions that they have been under, the social determinants of health, as we call it, they have a higher incidence and prevalence of the underlying medical comorbidities that when they are present, they give you a greater chance of getting a serious outcome with hospitalization and death. And in fact, that is the case in my country, that if you look at the rate of hospitalization per 100,000 population of African Americans, Hispanics versus whites, it is multifold greater among the minority populations. And if you look at deaths, it's 1 or 2 times greater among minority populations. Those health disparities are a reflection of things that have been inherent in our society for forever. And if there's one, I think, positive thing that comes out of this outbreak is the realization that we really need to do something about those health disparities. So I think it's a little different than stigma. It's related indirectly to stigma, but it goes beyond stigma. It goes to the structure in the country that has allowed that to happen.
These health disparities have been known about for years, though. What is it about COVID-19 that's put them into such stark relief?
Well, the consequences of a person who is an African American or Hispanic, who the incidence of diabetes, hypertension, obesity, chronic lung disease, heart disease is much higher in that population. You don't notice it, even though you should, when it's sort of there a long period of time. Then when you get a disease like COVID that specifically kills people with that type of underlying condition, then all of a sudden a bright spotlight goes right on that and says, oh my goodness, we really need to do something about this. And like I said, I hope if anything comes out of this terrible ordeal that we're going through, that it is a realization that we've got to address these health disparities.
On that, and probably our last question, a question sent in from Pejman Keshvadust, who says, there's a whole new generation of doctors who are training as medical students right now. What do you hope they've learnt from this pandemic that they can take into their practice?
Yeah, I think what they can take into their practice on the outside is that bad things can happen, and bad things are pandemics, and that we really do need to be prepared for that at every level, not only just in a public health level, but in a local level of taking care of patients. The other thing I think that we've learned is how extraordinarily courageous our healthcare providers have been. They should be very proud of themselves. If there ever is a hero and a heroine in this, is our doctors, our nurses, and our other healthcare providers. They've really risen to the occasion. And I think they've proven to themselves that they can do that. So I think when all this is over, they will feel that they've accomplished something that's most extraordinary and historic.
And what do you hope the general public takes away from it, apart from just general public health messaging of cleanliness and being aware of pathogens?
Well, I think it's what you said. It is an awareness that this can happen. And I think the resources that we as a global community needs to put into this, I mean, I don't think you could have any more cogent reason to do that than to just look at what we've been through as a global community over the last 14 or 15 months. That's got to be a big lesson learned.
Absolutely. Well, thank you so much to our audience for tuning in to the inaugural David Cooper Lecture with Dr. Anthony S. Fauci. Dr. Fauci, thank you so much for joining us and for sharing your insights.
My pleasure. Thank you for having me.
To hear about upcoming events and podcasts, you can subscribe to the UNSW Centre for Ideas newsletter or visit centereforideas.com. Thank you for joining us, and bye.
Thank you, Dr. Fauci and Tegan, for sharing your conversation with us. I imagine many people who joined have been affected by the HIV or most certainly COVID pandemics in some way, and have been drawn to the topic because of its ability to both unite and divide us. And thank you for your time and perspective for the inaugural David Cooper Lecture, not only in honor of Dad's work and legacy, but also in reaffirming how science and research has the ability to progress humanity when we take the time to reflect upon and integrate the many lessons of the past. Now to my dad, David Cooper. Mum, Beck, and my own greatest privilege was having a husband and father who was as incredible to us as he was to the world. In his home life, he demonstrated an enormous amount of trust, offbeat humor, and generosity. He was always available to listen when we needed to be heard, gave the best hugs, would keep us laughing with his endless quirks, and would always tell us how proud he was of who we were, not just of what we achieved. In his work life, he made small gestures that showed he cared about the people around him, teaming up with the Sisters of Charity at St. Vincent's to give human touch to patients with HIV when others wouldn't. Sharing medical clinical insights with colleagues to advance science, not himself. And signing us up for a Cooper family Mardi Gras debut, us in fluoro spandex, Dad with a head full of glitter, as we danced down Oxford Street, earning him the adoration of many of his patients, colleagues, and us. On their own, these examples were everyday acts, small gestures that over time significantly changed the lives of others. So many people were involved in Dad's journey, people like him whose commitment to care, courage, and respect added up to leave a significant legacy, one that will have an everlasting impact on the people around them. In honor of Dad's vision for equitable access to healthcare, the Kirby set up the David Cooper Memorial Fund, which will continue to be dedicated to finding infectious disease treatments and cures for all. We hope that the impact of his work and the kindness he embodied will live forever, and despite our loss, he will continue to save lives. How grateful we are to have known him, loved him, and been touched by him.
We work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement, and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.